Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. Low dose, long gain, targeting the tumor yet fueling the immune system. This podcast that is prescribed by Dr. Nathan Goodyear podcast, I want to talk about low-dose metronomic chemo. I've talked about chemotherapy in the context of the unholy trinity. That's chemotherapy, surgery, and radiation. Actually suppressing the immune system, though it could shrink a tumor, actually accelerating the mechanisms by which the cancer spreads. Why is that important? 90% of morbidity and mortality is when cancer spreads. Yet if we lower the dose of chemo, give it more frequently, we get this concept called lower dose metronomic chemotherapy, and it actually opens up more doors of possibility for treatment, but at the same time actually helps to improve the long-term outcomes. And so when you look at the show notes of this podcast, you'll be able to find the supporting evidence, and it's voluminous, of this research supporting low-dose metronomic chemo. Now, the concept here is to come up and define the concept of low-dose metronomic chemo, talk about the mechanisms of actions, the clinical evidence. You can't do a deep dive in this time frame of 30, 45 minutes, but then also talk about the practical applications and then where we may go in the future with this concept. Now, low-dose metronomic chemo is kind of a broad umbrella term that could include other terms such as fractionated chemo, metronomic chemo, low-dose metronomic chemo, insulin-potentiated low-dose chemo, insulin-potentiated therapy, and even now ultra-low dose. And I'll even provide a new term that has entered the market called immunogenic chemotherapy. So you can see not even the words that we use to describe this mechanism are in alignment. And you'll see in a second that the definition is not in alignment, because when we look at what is low-dose chemotherapy, we have to first look at what is full-dose chemotherapy, what I call maximum to tolerated dose toxicity. It's taking a toxin, giving it to the body, taking it to the point where, yes, it destroys cancer cells, but it destroys everything else. So what it does well, but understand rapidly dividing cells are not just confined to cancer cells. Immune cells, gastrointestinal cells, many other cells are rapidly dividing. And this in turn is some of the side effect profile associated with chemotherapy here, because it destroys the immune system. And research suggests it could be irreparable. But low-dose metronomic chemo dosage, pulling back from that full dose, about 10 to 30%, but no clear defined percentage. So if somebody's telling you they're giving you low-dose metronomic chemo and they're giving it to you at 50%, it's not low-dose metronomic chemo. And if they're giving it to you then frequently as if low-dose metronomic chemo, guess what? You're going to be getting, and you're going to be accumulating very rapidly the toxicities associated with chemo as if you got 3 months of full-dose chemo. You'll still end up with the same immunologic damage. But here's a definition from a 2019 article. The 2019 article is entitled Metronomic Chemotherapy, a Systemic Review of the Literature and Clinical Experience. I encourage you to check it out. But their definition was, metronomic chemotherapy is currently used for frequent and regular administration of lower doses of chemotherapeutic drugs with minimal drug-free time intervals, so less time in between, not 3 weeks, but weekly, or maybe 3 to 4 days, or simply lowering the dosage, giving longer times in order to establish a prolonged and lower active range of plasma concentration. So avoiding those high peaks, which create massive off-target toxicity, give lower peaks and basically broaden the anti-cancer effect, and thus also limiting the off-target toxicity. This enables an improved side effect profile. How much? We'll touch on in just a moment. So we have to go to the conventional high dose or maximum to tolerated dose toxicity dose, down to the fractionated of some percentage, then low-dose metronomic chemo, and now even the ultra-low dose. So those would be the four broader categories. And so if some other clinic or doctor gives their own kind of verbal spin to it, such as fractionated or not, it's still in this arena, but you have to ask them, what is the percentage of the chemo and what is the intent? Is it to be on this low-dose metronomic chemo weekly for the rest of your life? Or is it to serve a purpose in a point in time? And again, low-dose metronomic chemo typically in the range of 10 to 30%. No universally agreed upon definition, regular administration, lower dose, minimal side effects. Now, a new term has really popped up since about 2018, what's called ultra low dose chemotherapy. And this is really expanding the concept of what's called chemo-immunomodulation. See, the word chemotherapy, chemical therapy, has nothing to do with cancer, the origin of it. It was actually Paul Ehrlich in the early 20th century, and he said, I want to treat syphilis with one drug, salvaricet. So he said, I'm going to treat one disease with one chemical. It's only in the 30s and 40s into the 50s when this transferred this meaning into chemotherapy as it relates to cancer. But here, through this ultra low dosing, or lower dosing, but here lower dosing under 30%, even lower, 15, 10%, you actually get modulation of the immune system. So you're actually using a cytotoxic agent, chemotherapy, to modify the immune system. Remember, cancer is modifying the immune system. It reprograms many things, epigenetics, metabolism, but here it's reprogramming the immune system to recruit the immune system to it and actually turn the immune system to protect it in a pro-tumor immune environment and actually protect against the immune system. It turns the immune system on the immune system. In fact, research has shown that cancer cells will actually create nanotubules to tunnels that actually basically screw into immune cells that they've recruited in there, and they steal their energy source, mitochondria. So not only do they render these T cells and natural killer cells impotent from an immunologic perspective, but they actually steal their capacity to fuel, to actually replicate and grow faster. And so here, this lower dose, ultra low dose is leveraging the immune system to create a acute but long-term therapeutic effect instead of going to war on the immune system. It's a massive shift in thinking. And honestly, that's what we do at the Williams Cancer Institute. Instead of looking at a war concept, we're looking at the immune system as our friend and ally and something we must absolutely harness a relationship to empower, activate, train, because the best answer to cancer is never get it, but beyond that, the best answer to cancer is the immune system doing its job and targeting all enemies, foreign and domestic here. Domestic is the cancer category. Now, when we look at this immunogenic chemotherapy, it's this kind of new phenomenon where they're using this ultra low dose chemotherapy to modulate the immune system, actually create an immunogenic immune response. This is important to understand, immunogenic, because when we look at most solid tumors, per the research, again, check out the show notes for this podcast episode, most tumors, the majority of tumors are cold tumors. This means that in the tumor microenvironment where the immune system should be seeing the threat that is the cancer and going to warpath on the cancer, though I really don't like using that terminology, everybody understands what that is. Here, that area is a desert. It's dry, it's incompatible. There's no immune cells there whatsoever. Thus, the immune system can't see or recognize the tumor. And that's called a cold tumor. But if we can turn that desert, that immune desert, that cold environment into a hot environment, that is immune infiltration, immune activation, now we have the capacity to embolden and empower the immune system to infiltrate, penetrate, and target the tumor. And we can do that through ultra low dosing of chemotherapy, modulating the immune system, turning cold tumors hot with chemotherapy. At the Williams Cancer Institute, we're doing that through intratumoral ablation, intratumoral immunotherapy. And so when we give intratumoral immunotherapy, we're giving microdoses of chemotherapy, immunotherapy. chemo-immunotherapy there intratumorally. That's what we're doing, providing distinct immunologic effects. So when we look at immunogenic chemotherapy, let's describe the mechanisms here. First, we get chemotherapy-induced cellular stress. We get endoplasmal reticulum stress, we get DNA damage, we get excessive reactive oxygenation species, oxidative stress, and all of this triggers an immunogenic cell death. This immunogenic cell death releases many different components of the cancer cell that's dead, including damage-associated molecular patterns. And this, coupled with dendritic cell activation, allows the dendrites, these immune cells that engulf these danger signs and these antigens of the cancer cell, to thus create what are called tumor-associated antigens. It starts to generate a reaction against the dead pieces of cancer cells, but more empowered, more emboldened, because they have these other danger signals that were released with it. And then what you get, these antigen-presenting cells, they then begin to prime the targeted immune memory. They recruit and prime CD8 cytotoxic T lymphocytes. These are the T lymphocytes that are designated to basically go on the warpath directly against cancer cells. But also things such as CD4 helper T cells. And then they expand the clones of these T cells so that it's not just that these are primed, these are now activated, but they're now cloned. So we have developed a targeted, precise T cell that is primed, but now it's cloned into an army to go and do the job locally and systemically. So then what happens, we get tumor trafficking and effector infection. So these circulating tumor lymphocytes actually go into the tumor microenvironment to trigger an immune system locally. And they also modulate the immune system. What we also see here is we see a reduction in the immunosuppressive environment within that tumor microenvironment. Some of that is by reducing of T regulating cells and myelin-derived suppressing cells, and others are by simply influx of these cytotoxic T lymphocytes, more of the Th1 dominant, particularly here the effector. But we also see that there's an upregulation of major histocompatibility complex type 1 expression on the tumor cells, which is going to enhance the immune recognition and thus the training that we so want. And then out of this is, again, what we do at the Williams Cancer Institute. It's not just a short-term immune effect, it's a long-term immune effect. It's both. What we get here is we get a local immune activation, and this gets transferred to now go out as memory cells to target distant, untreated tumor cells for a sustained, durable systemic response. That is the abscopal effect. Ab away, scopus from target. That concept first described in 1953 by Dr. R.H. Moll. We employ that at Williams Cancer Institute with intratumoral ablation, intratumoral immunotherapy. But with the ultra-low-dose chemo-immunotherapy, you can even achieve that as well. But I think it's important to understand, if we did low-dose, ultra-low-dose chemotherapy 2 times a week, weekly, and it was done for 18 months, you might as well just do 3 to 4 months of full-dose chemotherapy. You have the same problems, the same side effects, the same off-target toxicity. So the core principles of low-dose chemotherapy include frequent administration, lower dose, sustained plasma exposure, multiple anti-cancer mechanisms of action, which we'll talk about in a second, and then reduced toxicity. And I think this reduced toxicity is critical, because if you go to war on a tumor and you lay waste to the tumor and you lay waste to the rest of the body, the quality of life is wiped out. We have to better balance in the arena of oncology the ability of targeting the tumor and the ability of maintaining the quality of life. The concept that we go to war and then we hope you survive, and then we hope you recover, and then we hope you heal, and then you start to live, that's outdated. What we need is an anti-cancer treatment strategy that not only helps you to heal, but as you target the cancer at the same time. We don't have to wait. They should happen at the same time. Now, the anti-cancer mechanisms of action of low-dose chemotherapy are widespread. It's multifactorial. Now, maximum tolerated dose toxicity has one goal: carry the body, carry the cells as a whole to the point of excessive toxicity, and then pull back. People go, why do we do chemotherapy every 3 to 4 weeks? Well, it's because you couldn't handle the full dose toxicity of the maximum tolerated dose toxicity chemotherapy is every week. Your immune cells couldn't handle it, your healthy cells couldn't handle it, and so you have to have a point of recovery. And of course, the much of the point there is the recovery of the immune cells. But again, as the accumulation happens there, the immune cells don't recover. They don't. So when we look at the low-dose metronomic chemo, there still are direct anti-cancer effects. It's still directly cytotoxic in its action against cancer cells. Now, definitely less than the full dose, but it's also massively less in the non-cancer cells. It triggers tumor cell senescence. This is something that Dr. Williams and I talk a lot about, and this is intertwining the hallmarks of aging and the hallmarks of cancer. Cell senescence is when cells stop replicating, but they remain metabolically active. Now, this is a key manner to stop cancer in its track, but cell senescence can also drive cancer recurrence and cancer metastasis, so you must now bring in what are called senolytic therapies to actually target and destroy these cell senescence. But when cancer is growing rapidly under control, stopping it and putting it into cell senescence is a good first step. Sometimes when cancer is progressing, you may not take that progression to immediate regression. You can take it from progression to stable, now to regression. It also stimulates programmed cell, particularly via apoptosis, triggering this programmed cell death mechanism to kill cancer cells, whereby it kills itself. And this in turn will also trigger the immune system. It also targets and reduces cancer stem cell population. So those cells that are backup copies that we want no part of here in cancer that work to actually lead to recurrence, lead to resistance, and in part lead to metastasis. So one of the big problems with full-dose chemo is it forces mutation. It forces the hands of the development of resistance. And here you can actually take cancer cells or tumors that are resistant to chemotherapy, give lower dose, and actually restore chemosensitivity to the chemotherapy of which the tumor was resistant to, now becomes sensitive to. But it's primarily through its off cytotoxic effects that allows it to resensitize the tumor to the chemotherapy. Now, the primary mechanism of action here is the anti-angiogenic effect of low-dose metronomic chemo in that 10 to 30% perspective. And this is, in fact, why the low-dose metronomic chemo, really why it came to be. Full-dose chemo, or maximum tolerated dose toxicity of chemotherapy, it doesn't target angiogenesis. Angiogenesis is that rapid blood vessel supply growth that cancer so desperately needs to meet its rapid metabolic, rapid growth, because as cancer is growing so rapidly, it's outgrowing its vascular supply, and so it has to trigger mechanisms to actually promote new blood vessel growth, and it tends to be very tortuous, irregular, and not very healthy. That is called angiogenesis. There's also another process called neoangiogenesis. But here what's happening is this cancer growth is triggering hypoxia-inducible factor 1 alpha. And you can see that as cancer grows, it's outgrowing its blood vessel supply. It can't keep up with angiogenesis. So what happens, you get pockets of hypoxia. These pockets of hypoxia trigger transcription of hypoxia-inducible factor 1 alpha. This then triggers vascular endothelial growth factor, which promotes angiogenesis, meeting that blood vessel supply growth so that it can continue rapidly grow in a process of what's called replicative immortality. But also, it triggers angiogenic dormancy, which is the state where tumors cannot stimulate new vessel formation at all. So it makes them go dormant. So it's like cells that are growing rapidly become stable. They come into a homeostatic balance, but here they just basically go into dormant state. They can't promote angiogenesis at all. So number one, I'd say that the key aspects of what low-dose metronomic chemo provides, beyond the first smaller effects that I mentioned, the cancer stem cells, the direct cytotoxic effects, the chemosensitivity restoration, is angiogenesis, targets that. But here, one of the key aspects is the immunomodulation. And so these are the two key aspects that separate the low-dose metronomic chemo out from full dose. And this is why they've even done in studies the full dose in contrast and in combination with low dose in alternating sequences. But when we look at the immunomodulating effects of the lower dose chemotherapy, really twofold, in enhancing anti-tumor immunity and then affecting the tumor microenvironment. So when we look at cancer as a whole, again, most tumors are cold tumors, meaning the tumor microenvironment is desert for immune cells. It's cold, it's cold. And much of that is because of immune cells that get in there. T-regulating cells, myeloid-derived suppressing cells, even very rigid extracellular matrix play a key role in basically keeping the immune system out, keeping it in a desert situation. Yet what here the chemomodulation allows us to do with the low-dose metronomic chemotherapy, even the ultra-low-dose chemotherapy, for example, just like what we do with the intratumoral ablation and intratumoral immunotherapy, we're able to shift this desert environment, cold, into a hot by increasing the infiltration of cytotoxic T lymphocytes, increasing the infiltration of natural killer cells, suppressing, as I mentioned, those T-regulating cells, causing a shift in the T effector or cytotoxic T lymphocytes to T-regulating cell, creating a shift in anti-tumor immunity rather than pro-tumor immunity, stimulating antigenic maturation, dendritic cells, antigenic engulfment, antigenic presentation, T cell priming, and thus creating that immunogenic immunotherapeutic effect, but from ultra low dose chemotherapy. And see, even though this is great to modulate the immune system and be able to inhibit angiogenesis, modulate the immune system to shift from pro-tumor to anti-tumor, we have to understand it's still chemo given systemically. So I recommend when this is given, it's given for a prescribed shorter period of time. I'll repeat this time and time again. Low-dose metronomic chemo given weekly for 18 months, not any different than full dose given for 3 to 6 months. It's still going to have the same damage, and we'll talk about that in just a second. One area to look at too is what's called the neutrophil lymphocyte ratio. A lot of patients, as they go through treatment, particularly with chemotherapy, they go, how do I follow? How do I know this is working? Because we know that the specific tumor biomarkers that we so often follow, there's CEA in colorectal cancer, CA15-3, 27-29 in breast, CA19-9 in pancreatic cancer. These can be helpful, but overall they're not very reliable. I've seen stage 4 breast cancer as completely normal tumor biomarkers, and pancreatic cancer equally very early stage pancreatic cancer, yet it's, CA19-9 is in the 40, 50,000. So there's no correlation, it's all over the map. But if we look at the neutrophils to lymphocyte ratio, which is in the differential of your CBC, it tells us a lot about the immune system. So research has shown that metronomic cyclophosphamide chemotherapy, also known as Cytoxan, it'll reduce T-regulating cells. And this helps to normalize the lymphocyte component of the neutrophil lymphocyte ratio. A high neutrophil to lymphocyte ratio, typically above 4 to above 5, is a very negative prognosticating factor, and it shows a reduction in overall survival and a reduction in progression-free survival. But if we give low-dose metronomic chemo, it'll actually reduce this neutrophil lymphocyte ratio, which is going to show an increased immunologic response, that is, from shift from pro-tumor to anti-tumor. Even in pediatric sarcoma protocols, low-dose metronomic chemo has been shown to stabilize or reduce the neutrophil lymphocyte ratio. So if you are receiving chemotherapy, whether that's full dose or whether that's low dose, follow that neutrophil lymphocyte ratio. It doesn't need to be automated, it needs to be the actual determined CBC plus diff. And so what you're seeing here is a depletion of myeloid-derived suppressing cells, reduction of T-regulating cells, an enhancement of the T effector cells, CD8 cytotoxic T lymphocytes, and this shifts the neutrophil lymphocyte ratio lower. So we get increased lymphocytes, and we either maintain normal neutrophils or reduce them to actually lower the neutrophil lymphocyte ratio and improve the anti-cancer effect. Because full-dose chemotherapy, it has anti-tumor activity. Sometimes there's such a large tumor burden, we have to shrink it. And so we, even at the Williams Cancer Institute, said we got to reduce the tumor burden. Because if you can't reduce the tumor burden, the immune system almost can't, it doesn't have enough power. But it forces resistant clones to develop and to grow. And this develops overall selective resistance. Still clinically effective early, but it will promote resistance. It also promotes immune damage. And this also leads to metastasis via a variety of different mechanisms, which we'll talk about in a future podcast. But low-dose metronomic chemo equally has anti-tumor efficacy, yet it can actually prevent resistance. In fact, it can even restore sensitivity where resistance has developed. So when we look at the clinical advantages of low-dose metronomic chemotherapy, as described in the research, again, if we look at the definition, there's no clear definition of what is the percentage but typically it's going to be between the range of 10 to 30%, not 50%, not 60%, 10 to 30%. This leads to a 70% reduction in adverse events. Most of what creates the fear in cancer, when somebody hears that word, whether it's about themselves, whether it's about a loved one or a friend, is the picture that emboldens and imprints in their mind of what they're going to see, of walking down a chemo ward, a hallway, a large room of people receiving chemo. It's like life has been sucked from their veins, but it's been sucked by the chemotherapy in an attempt to destroy the cancer just enough more than the rest of the body. But here with low-dose metronomic chemo, 70% reduction. Amazingly enough, research has shown, we'll talk about it in a second, a virtually 100% comparable effectiveness of low-dose metronomic chemo versus full dose. Now, how many out there in the oncological world are aware of that? Contrast to the 70% reduction in adverse events, we have a 60% increase in quality of life. So maybe that picture, that imprint in our mind of people in chemo, in chairs, receiving chemo, all looking like death has been taken, life has been taken from them, and they're slowly getting death infused into the vein, which, by the way, is a toxicity. Maybe that is something that is by choice that we no longer need. See, the clinical evidence really points to the efficacy of the application of low-dose metronomic chemotherapy. And this is in both the preclinical space and the clinical space. So in the preclinical space, we have extensive in vitro studies. These are studies looking at basically the lower dose in a petri dish of cells of cancer, being directly cytotoxic against cancer cells. We've shown this, it's been shown, in numerous animal models to inhibit growth. It's been shown across the board in preclinical to be anti-angiogenic. It's been shown to be, in its immune profiling, immunomodulatory. Again, it can work one way to elevate the immune system, another way to suppress the immune system. Just because you stimulate the immune system or create inflammation, that doesn't equate to good or bad. You can stimulate the immune system, yet stimulate T-regulating cells, stimulate interleukin 10, stimulate transforming growth factor beta. These are immunosuppressive. But you can also stimulate the immune system in a way that's anti-tumor, cytotoxic T lymphocyte, natural killer cells. So we must equate and clarify what we're talking about when we mention inflammation and when we mention immunostimulation. Also, models have shown, again, the great effectiveness of restoring chemosensitivity where chemoresistance has developed. This is the preclinical. In the clinical, we have both phase 1, phase 2, phase 3 trials across multiple cancer types, retrospective, real-world, worldwide evidence to support its clinical efficacy. Of course, widespread case series demonstrating its effectiveness across the globe, and then long-term follow-ups have shown basically partial and complete responses with durable responses. And so when we look at the efficacy of advanced metastatic cancer, this low-dose chemotherapy approach provides disease control in not just stage 1, stage 2, but stage 3, stage 4 advanced cancer, including metastatic cancer. This is where cancer has spread outside of its primary tumor, and that's where 90% of morbidity and mortality happens in cancer. So even there, low-dose metronomic chemo works, and it reduces the side effects. So it has equal efficacy, doesn't destroy the body in the long term. It can support the immune system depending on how it's dosed. And it increases quality of life or maintains quality of life. Well, for the patient, that's a win-win-win. And we doctors, we're advocates for patients. And so that for us should be a win. And this slide, it'll be in the podcast, so check that out if you're just listening to this. But the clinical outcomes, looking at low dose versus conventional approaches, the overall response rate, the actual overall response rate for conventional full dose chemotherapy is just slightly better than that with low-dose metronomic chemo. But actually the disease control rate is just slightly better in the low-dose metronomic chemo versus the full-dose chemo. The progression-free, the same, and grade 3 to 4 adverse events, which basically is hospitalization, major intervention, massively reduced, well under 20% for the low-dose metronomic chemo and well over 60% in the full-dose chemotherapy. Again, it's the imprint of the image of the going to war on cancer with full-dose chemotherapy. It's designed to go to war. It's born out of war, born out of World War I, born out of World War II, bombing Little Pearl Harbor. But yet, when we transfer that war from the battlefield to medicine, and that battlefield of medicine concept to the battlefield of the body, we suffer. Our immune cells, our defenses suffer, and we don't have to. And again, a key meta-analysis was actually published in 2017, Efficacy and Toxicity of Low-Dose versus Conventional Dose Chemotherapy for Malignant Tumors, a meta-analysis of 6 randomized controlled trials. Here you'll see multiple other studies, also in 2024, a 2021, the Victor-6 study, and then European Journal of Cancer 2013, which is a systemic literature analysis. So multiple studies supporting the high efficacy and reduced toxicity and improved quality of life of low-dose metronomic chemo compared to maximum tolerated dose chemotherapy. So the key clinical benefits of low-dose metronomic chemotherapy are tumor regression, right? We want tumor regression, both complete and partial responses, sustainable, durable responses. We get reduced metastasis, anti-angiogenesis, immunomodulation, reducing that 90% cause of morbidity and mortality. But this then prolongs survival. The whole goal for treatment for cancer is to live and survive. Not for 2 months, not for an increase in 2.2 months, 2.5 months, but for an increase for 22 years for the rest of your life. We should measure success in weeks to months, as so often is the case in research that so much is driving the innovation today. We should be measuring success in decades. In decades, lives truly change. That's healing. And in that, we'll reduce the toxicity and enhance the quality of life. Give patients a life to live, a life worthy to live, as you heal them from a deadly disease like cancer. Now, most of the research leading evidence of it is in breast cancer. We have the entire month of October on Breast Cancer Awareness Month. And it's the most studied type when it comes to low-dose metronomic chemo, the largest number of published clinical studies, most comprehensive long-term follow-up, multiple phase 3 trials, comparing it with conventional standard of care. That term, standard of care. Standard of care, what does that mean? It's just what everybody's doing. Evidence across all cancer types, ER positive, PR positive, ER negative, PR positive, ER positive, PR negative, and then HER2 positive, HER2 negative. So triple positive, triple negative. The data is in neoadjuvant, before adjuvant, and then in metastatic settings, so in the worst settings there. And we use, and it's been shown, studies to be shown alone, but also in targeted or in combination with other therapies. So the evidence across different cancer types, breast cancer, colorectal cancer, non-small cell lung cancer, prostate cancer, ovarian cancer, pancreatic cancer, even the blood-borne, such as multiple myeloma, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, acute myeloid leukemia. So you can see both blood-borne and solid tumors, pediatric cancers, neuroblastoma, rhabdomyosarcoma, Ewing sarcoma, and even medulloblastoma. This is clearly a broad tool with chemotherapy in a low dose to target cancer in a broad way, but not destroy the body in the process. And again, the key clinical aspect here is dosing. So dose, whether not the high dose, but lower dose, more frequent dosing, and patient selection. Now, there are some times where a higher dose would be required. Again, reduce tumor burden in a short term to be able to then come in with an intratumoral immunotherapy approach. Because when you have such a dominant tumor burden, whether it's one large tumor, say 10 centimeters, or we have a bunch of smaller tumors which equate to 10 centimeters, that still creates massive disruption in the immune system, makes it really hard to activate the immune system on any level. So starting to summarize here, the dosing considerations, 10 to 30% of the maximum tolerated dose. And I'll repeat it again. If somebody's giving you 50%, it's not low dose. It's administered more frequently. It's administered at lower dose. And this creates a more sustained plasma level and avoids those high peaks that destroy off-target sites, such as the immune system. But where this really shines is in combination with other therapies. Now, I want to touch on really quickly here on insulin-potentiated low-dose chemotherapy. Because you'll hear a lot of people talk about IPT, or insulin-potentiated therapy, potentiated low-dose metronomic chemo, and low-dose metronomic chemo. Now the difference here is they're giving insulin prior to the administration of the low-dose metronomic chemo. The reason here is you're trying to elicit a hypoglycemic state to actually give an advantage to shifting the chemotherapy into the actual tumor cells. Cancer cells do overexpress insulin receptors at a significantly higher rate, even insulin growth factor receptors, and these will form heterodimers. And so by giving insulin, you're actually increasing the permeability of the cancer cell membrane, increasing the transfer of the chemotherapy across that membrane into the cancer cell to actually elicit a higher cytotoxic effect. Now this is if you're just going after a cytotoxic effect. So if you're looking at angiogenesis, if you're looking at immunomodulation, I don't think this really applies. But if you're looking at more just a direct cytotoxic effect, so you're really looking at a closed-minded, horse-blinded way of looking at chemotherapy, but you're wanting a lower dose, and you add insulin to it, okay, yes, you potentially could increase the transmembrane uptake of chemotherapy there to increase cytotoxic effect. But we can also understand its broader effects outside of that. So I've used both low-dose metronomic chemo and insulin-potentiated low-dose metronomic chemotherapy, and they will both reduce the dose as well as maintain efficacy and increase survival and quality of life. Now, what happens here is people get really confused about insulin. They say, well, we're here to treat diabetes. Well, here what we're doing is we're just working to modulate the membrane of the cancer cells, of which they express a receptor, of which we can now use to increase the uptake of the therapy that we can use to target for its direct destruction. People go, how can that be? That's not possible. It's like, what do we do with aromatase inhibitors when estrogen receptors express? We're basically doing the same thing. We're doing the same thing. We're not giving chemo typically with that. But where the low-dose metronomic chemo, I think, really shines, again, indefinite, it's the same thing as full dose. It's the same thing as full dose. I don't care what they say. But when we use these in conjunction with other therapies, there's no one answer to the cause of cancer. There's no one answer to the treatment of cancer. It's about stacking these therapies together to precisely target multiple aspects of a cancer. Targeted chemotherapy, so targeted therapies, immunotherapy agents, integrative therapies, radiation, hormonal therapies, metabolic interventions, all are great to stack with low-dose metronomic chemo, with or without insulin. Now, I've touched on this and I've repeated that low-dose chemotherapy given weekly for 18 months is really going to lead to the same off-target toxicity and damage to the immune system that you can get from full dose in 3 to 6 months. It just takes longer to get there. You'll still get the bone marrow suppression. You'll still get the immune compromise. You'll still get the process by which cancer will spread because of immunosuppression. But we also see evidence where it damages the gut microbiome. This comes to the point that it's still chemotherapy at the end of the day. Thus, it should be used in a concise, specified time frame in conjunction with other therapies. It shifts the microbiome. Now, why is this important? We know that the microbiome is key to the immune system priming and immune system support. Just look at fecal transplant. In melanoma, in renal cell carcinoma, colorectal cancer, fecal transplant increases immunotherapy efficacy by 3 to 4-fold. That's the extreme version of trying to modulate the gut microbiome. But here, chemotherapy is modulating the gut microbiome in a different way. It also damages the integrins, which are connecting the tight junctions between the gut epithelial cells and actually leading to leaky gut. This breakdown leads to systemic inflammation. This systemic inflammation drives cancer. It's the bed in which cancer lies. It also depletes the small chain fatty acids. These are the healthy metabolites produced by healthy bacteria within the gut microbiome that are wiped out or harmed or depleted by chemotherapy. You get also the expansion of pathogenic bacteria. So you get a decline in the healthy bacteria. You get an uptick in the pathogenic bacteria. This all leads to a concept of an inflammatory dysbiotic signature that is going to drive cancer. Research has shown you can shrink a primary tumor, but then you spread it. Now the mechanisms by which you do that is multiple. You damage the gut microbiome. you damage the gut epithelial lining, leaky gut, you damage the immune system. The total leads to a compromised immune system, so that then we have a short-term victory, but we set the stage for the long-term loss. That's called pleiotropy antagonism, which is making a short-term sacrifice for a short-term gain, and yet it turns around and bites you in the backside. And this then leads to a long-term loss. That is metastasis, 90% morbidity and mortality associated with cancer. So the exciting thing is we're going to be expand this into the future, but what we need is more precise biomarkers to be able to guide us in which low-dose metronomic chemotherapy is advisable, when it's indicated, but also how to follow through that treatment. Novel combinations of the low-dose metronomic chemo, or insulin potentiated therapy, whatever is being chosen there, how that can be used in novel combinations. And I'm really excited about the low-dose metronomic chemos in combination with intratumoral PEF, intratumoral cryoablation plus intratumoral immunotherapy. And then expanding the applications outside of that, just as what I mentioned there. And then we need more mechanistic understanding of this. The problem is a lot of the forced pressure and research is only to support the full-dose chemotherapy. But even radiation has moved away from the just broad body treatment of radiation. They understand that they can kill the cancer cells, they can kill the tumors, but they wipe the body out the same. And so now they move into stereotactic mechanism, very pinpoint target. Yet chemotherapy seems to be resistant to that push. Yet here, with low-dose metronomic chemotherapy, it is that same push. More targeted, more fine-tuned, more precise, and that's what we get. So the key takeaways here, multiple validated approaches of how low-dose metronomic chemo, multiple mechanisms of how it provides an anti-cancer effect. Instead of just one at the full dose, we open up the floodgates for the opportunity to target the cancer in a multitude of ways. Multiple augmented or synergistic therapies that it works well with. Strong clinical evidence, both preclinical and clinical. And then this is a patient-centered approach. So when we look at what we are as physicians here in the arena of treating cancer patients, we're patient advocates. So we should work to target a tumor, but we should objectively have the simultaneous goal of healing the body. And so we as doctors, we are teachers, we are patient advocates, but as physicians, the same word as doctor, but in Hebrew, we are healers. And low-dose metronomic chemo definitely fits more into that pillar of healing, but helps us to be able to target that tumor nonetheless. So this is my thoughts on low-dose metronomic chemo. Please check out the show notes where I describe actually the evidence there supporting, and I encourage you to take a deep dive in and go in there and just go down that rabbit hole of that research on low-dose metronomic chemo. We really need your help here to grow the followers of Prescribed by Dr. Nathan Goodyear so we can get this message out of integrative oncology to everybody, loved ones, family, friends, colleagues with cancer. Even share it with your oncologist because this is evidence-based. See, in the arena of integrative oncology, we don't have to run from the science, we simply have to follow it. So share this with those that you think would benefit it, both patient and doctor. As always, thank you for joining us on this podcast. We look forward to seeing you on the next Prescribed by Dr. Nathan Goodyear podcast.
Thanks for joining us on this episode of the Prescribed Podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.